Welcome to Chronic Choices Critical Voices, a discussion series that brings together diverse perspectives on health policy and the lived experience of millions of Americans managing one or more chronic conditions. I'm Candace DeMatteis, Vice President of Policy for the Partnership to Fight Chronic Disease. In this discussion series, we're talking with important stakeholders across the healthcare continuum who know that innovation, coverage, and access are all critical components of improving overall health outcomes for people living with chronic conditions. We also know that no matter who you're talking with, lowering healthcare costs in the United States is a high priority. But when treatments are delayed or denied, it isn't just a cost problem. The ripple effects are far and wide for patients and their families. Today, I'm happy to welcome Adina Lasser. Adina is the Director of Public Policy and Government Relations at the Alliance for Aging Research. The Alliance works with patients, federal agencies, elected officials, and partner organizations to advance policies that support research and healthy aging. Adina leads efforts to increase investment in foundational research, introduce patient protections, and help address the affordability of healthcare. And today, we'll be zeroing in on most favored nation proposals that relate to drug pricing in the United States and refer to pricing in other countries, and talk about what's at stake for access, coverage, and outcomes. Adina, thanks so much for joining me today.
Thank you so much for having me.
Let's dig right in. I've heard that many groups representing older adults, representing people living with chronic conditions, representing people who live with disabilities, have serious concerns about foreign governments' reliance on what's called the quality adjusted life year, or QALY, and they use that in setting government price controls on drugs in their countries. So before we start talking about MFN, or most favored nation, I wondered if you could help explain what is a QALY and what problems does it pose.
Yeah, thank you so much for having me and for the opportunity to talk about this important issue. So, the QALY is a very simple math equation that governments across the world, but not the United States notably, use to set a price threshold for what treatments they're willing to pay for. And the way that it works is it assigns a value to a patient's level of health. And there's all kinds of concerns with that, right? The number one being that it's not very palatable for someone to have a value assigned to their level of health or their life. It also systematically undervalues the lives and health gains of older adults and people with disabilities because it tends to assign a lower value to years lived with illness or disability or other chronic conditions. The QALY is used by many of the countries in this sort of OECD basket that the administration chose for the MFN proposal, meaning that we'll be essentially importing their prices and their price calculation system. Why does that matter? This matters because the QALY bakes age and disability bias into coverage and pricing decisions. Even when treatments provide meaningful benefits like slowing disease progression or preserving independence or even reducing caregiver burden, it also fails to capture outcomes that matter most to patients. So things like their cognitive function or their quality of daily living, their symptom control, being able to stay at home rather than in an institution. They fail to capture the positive impact of excuse me. They fail to capture the positive impact of preventative treatments, something like vaccines. And like I mentioned before, people just find it off-putting to have that number assigned to their health. So this would primarily impact older adults, people living with disabilities or chronic conditions like Alzheimer's, people with rare diseases and neurodegenerative diseases. These are very notably the very populations that the Medicare program aims to serve. And advocates have worked really hard to get these banned under federal statute, including and especially in the Medicare program, because of the way they're discriminatory. And so importing them indirectly through this price matching system would undo all of that work. I also want to make it clear at the outset of this conversation that the MFN proposal that the administration has put together healthcare has nothing to do with the price that the patients pay or beneficiaries pay at the pharmacy counter. This is about saving the government money. And so I think a lot of this conversation would have a different tone and tenor if we were actually looking at saving people money in their day-to-day lives on their incredibly expensive healthcare. But that's not what we're talking about today.
So if I understand correctly, then a QALY can say that potentially just treating someone with a chronic condition or someone who has a disability or someone who's older may be worth or less worthwhile or less valuable than treating someone who could be restored to what perfect health, I guess, or health that is more, considered by that country to be more invaluable. Is that accurate?
That's exactly right. And so if you think of it as a real world example, it could be something like, well, it's not worth paying for your grandmother's hip replacement surgery because we could be doing that hip replacement for somebody else, maybe somebody
Mm.
who's younger or who could use that hip longer. But the US hasn't had to ration care like that ever. And don't, I think that it's important to advocates, it's important to me that we not take in that kind of age discrimination or disability discrimination via these proposals.
How could you're a research organization and really focused on research to help improve healthy aging. How
Mhm.
could this MFN proposal affect research and innovation for older adults in America?
It's a great question. MFN will reduce the incentives that industry has to invest in therapies that primarily serve older adults, right? Um, Particularly in areas like I've talked about, like Alzheimer's, cancer, cardiovascular diseases. What we're doing is we're tying the prices paid by these foreign governments, importing this rationing of care, and creating price ceilings which are disconnected from US patient needs or clinical value or innovation risk, especially for these more expensive therapies like complex biologics or something that's first in class, something that's meeting an area of previously unmet medical need. These for diseases with these long and expensive R&D timelines, that means we're scaling back clinical trials, we're delaying or abandoning high-risk research, we're prioritizing markets or disease areas with clearer pricing signals, right? And then for older adults, this could mean long-term, very long-term, right? Fewer new treatment options or slower progress against the diseases of aging. And then also less investment in therapies that improve things like cognitive function or independence.
It comes to disincentivizing research and innovation. Are you saying that the most favored nation proposals would mean less investment in research, only research affecting older adults, or research in general, or both?
It's definitely both. I think the focus that I'm putting on older adults is because we're talking about the Medicare program, right? So these are prices that are going to impact drugs that are primarily taken by older adults, and therefore, when somebody like a an investor or a venture capitalist is looking at where they want to put their dollars, if they know that they're going to have less return on investment for conditions that are paid for by the Medicare program, the odds are that they're going to try to turn into other directions, maybe into conditions primarily impacting younger people or more able-bodied people, that kind of thing. But it
So
will
what can,
impact
oh,
research.
sorry.
I'm sorry. I was just going to say, but it will impact research across the board. So.
What concerns you the most about this proposal, or I should say these proposals, because it's more than one, for the Medicare program and using most favored nation and its dependence, indirectly perhaps, but certainly its dependence on metrics like the quality adjusted life year? How does that affect or potentially harm achieving better health outcomes for older adults?
I think at the highest level, both MFN and the QALY, they reflect a health policy mindset where we're prioritizing short-term budget predictability, not even necessarily savings, but predictability over long-term population health, especially for older adults. I am concerned that it's shifting decision making away from patients and their clinicians when it's already hard enough for an older adult to feel like they're having a meaningful dialogue with their clinician, now you're involving their payer and also this sort of like global market basket at the highest level for what treatments they're going to be able to get, right? And so it's taking that decision-making power away from patients, which that's not a US health system value, right? They're also they risk worsening long-term outcomes. They are discouraging this investment, like I talked about, slowing progression, reducing complications, and then they're embedding this structural age and disability bias into our policy. That's not just a technical issue, right? It's a values choice.
This policy, as I understand it, and I believe you've mentioned before, really focuses, doesn't necessarily result in savings for the Medicare
Mhm.
beneficiary, which I think is a little, what people are anticipating and expecting. So, what are some better answers to actually lowering drug costs for older adults and for other Americans at the pharmacy counter or at the doctor's office?
I love this question. It's something that, we at the Alliance think about a lot. There's so many things that go into the actual price that you pay at the pharmacy counter, right? So one thing is it's kind of a myth that we're just talking about prices here, right? We're also talking about access barriers. So let's address things like the overuse of prior authorization or step therapy, where you have to start. So, prior authorization is when your doctor has to sign a special form allowing you and justifying to your insurance company that you need this medication. Step therapy is when you are given a treatment by your doctor and told that you need to try and fail on less expensive treatments first. So let's take care of these kind of real world access issues, right? And then let's target out of pocket costs directly. One thing that I'm really excited about is that now we have a cap on the total out of pocket costs that a beneficiary spends on the Medicare program, which is $2,100 this year. But we are still seeing things like your plans are shifting co-payments where you have a set amount of dollars that you pay for a treatment over to co-insurance where it depends, the price that you pay depends on the total cost of your medicine, meaning that if you're taking a more expensive medicine, you're responsible for more out-of-pocket costs. That's a real concern. And then, of course, there's this sort of pharmacy benefit manager middleman reform where there's kind of a monopoly and therefore monopoly pricing on the people that set your formulary. Or by the people that set your formulary. So I think making that PBM reform, forcing them to pass through savings and be transparent with how they're setting their prices can go a long way. The other, kind of idea that we should consider is promoting competition among manufacturers, right? So let's speed up approvals. Let's increase the uptakes of generic and biosimilars. And then, let's address any of those formulary concerns that block competition. And then, of course, if we're talking about value framework, like the QALY, which there's been some push to bring that to the US for a number of reasons that, I personally find pretty concerning. But there are value frameworks that incorporate the kind of outcomes that patients care about, right? So let's look to those value frameworks. Let's look to how often do I have to go to the doctor? Maybe there's a drug or an intervention or a therapeutic that could help me lower my number of days actually having to engage with the health system, right? Let's look at caregiver impact, quality of life, and let's like reject those metrics that discriminate, but maybe bring in some value-based care that actually makes a positive difference in the lives of older Americans and all Americans. And then, of course, there's always investing in prevention and early diagnosis. I know, Candace, you and I engage so much in the Alzheimer's space, and there's been this incredible innovation for blood-based biomarker testing, meaning we can just take a blood sample and know pretty well if you have Alzheimer's or not, which is a huge innovation over where we used to be. Right now, we're having trouble getting coverage for it. Let's make sure that we're covering those diagnostics so that we can catch things earlier and have interventions earlier, which will prevent that, much more expensive down the line healthcare spending that we so often have to do because we couldn't intervene at the beginning stages of something. So there's so many different directions that we could go. That's a very small kind of number of examples. So let's make sure that we're, putting our policies where our values are.
Absolutely. And I love that sometimes it's the focus on price, and it's really more about what the government or insurers pay rather than what the consumer pays. But what we're concerned about is consumer access,
Yes.
consumer affordability. And I love that, as you mentioned, there are so many better ways that we can improve access and affordability for the people who depend on the medicines that they need to improve their health, and diagnostics and other treatments that ultimately help us be healthier and save the whole system money.
Absolutely. And people are smart, right? People know that if you tell them we're going to be saving money and then they're not saving money, people know that that's the case, right? And so you're never going to be able to dupe people into just accepting this narrative that they're being given. And I think that's an important note, right? We need to trust that people know what's going on financially and in the health system and actually speak to the day-to-day lives of everyday Americans.
Absolutely. And empower those important decisions so that they
Absolutely.
feel like they have the power to make those decisions and choices and urge for change that actually does benefit them.
Absolutely. I couldn't agree more.